entheogenic integrative medicine for relief of spiritual and existential suffering in serious and chronic health conditions, trauma and beyond. And yes, Shinitra, I do consent to the recording. I think you asked me on the email, so please go ahead. And so awesome medicine, here we go. Next slide is, let's see if I can get this to advance. Come on. Okay. I am a medical advisory board member for Cannabis Therapeutics, which makes CBD and cannabis products. I help them think about their formulations and how to actually get better access in hospice populations. The objectives that I want to cover with you is to talk about existential stress and distress as it relates to illness and being mortal in general, talk about the integrative spiritual dimension of health, talk about the fifth wave in public health, the integrative turn, and then how to develop healthcare practice frameworks that are informed spiritually and trauma informed. Briefly touch on polyvagal theory, awe, and meaning making, and then talk about entheogens and entheogenic integrative care and define that, and go into higher level clinical evidence on entheogens, practice perspectives, and ways to practice entheogenic integrative care with substances such as cannabis, ketamine, psilocybin, and ayahuasca. So it's a big roadmap. We won't probably get to everything, but I'll try to make it concise so we can get to some questions. So what is existential anxiety? In hospice and palliative care, professionals are oh, my slide is cut off at the end there. I'm sorry about that. It just says that professionals are trained to diagnose and treat individuals with clinically significant existential distress associated with life-threatening or life-limiting illness. But the problem is there's not a whole lot we can do about it aside from whole person palliative care. The common themes that you see are a lack of meaning and purpose, loss of connectedness, thoughts about the dying process, struggles around the state of being, difficulty in finding a sense of self, loss of hope, autonomy, temporality, suicidal ideation, desire for hastened death, that kind of thing. So it's quite a thorny and complex scenario. And I think it's worth noting that there is also a my slides are all cut off. So let me see if I can switch just a second to this other screen. I'm sorry about this. 1 second.
I think you might see them as cut off, but I think we're seeing the whole slide.
Oh, are you? Okay.
Yeah.
So I'm sorry. I'm glad you get to see that. Okay. Mine is not showing me that. Okay. So let me turn that back on then. Just a second. Okay. Sorry. Anyways, the next slide I'm talking is about something called the Damocles sword effect. In the cancer survivorship literature, they talk about this patients really struggling with fear of cancer recurrence and the living in a constant shadow of a previous cancer diagnosis. So you can see this artist's rendition of a patient here, who's ostensibly completed chemo treatments, but then there's this horse-haired sword hanging over her head. Any moment she tries to go out and enjoy post-cancer treatment life. So I think this is actually these examples illustrate sort of some of the severe ways in which we see existential distress in palliative care. My slide is advancing. There we go. Okay, but it turns out that really existential stress is just part of being human, being mortal. From the time we develop awareness of mortality, there's existential concerns that can be mild to severe depending on a variety of factors, such as actual or threatened death, injury, illness, deprivation, or other trauma. And I'm sure in this current COVID pandemic situation that we've really, many parts of the world are still deeply mired in, this has come up quite a bit more in the general population. And I think it's also interesting to note that I think existential stress comes up also around social disturbances, crises in social acceptance, ostracization, betrayal, oppression, because of the critical nature of socialization in our development. Hunter-gatherer clans, as we evolved in, anytime you had a threat to be no longer in the group, it was essentially, you could die. Survival was at risk. So I think this is a critical point around existential distress. R.D. Laing, the psychiatrist from Scotland, famously observed, life, you see, is a sexually transmitted disease, and there is a 100% mortality rate. So that he kind of is quipping that really existential stress is universal, and this is also why spiritual health and well-being needs to be seen and understood seriously as a core dimension of health because of this universal situation. So how to define spirituality in health? This is the consensus definition that many in palliative care are familiar with by Polchowski et al. You know, and the critical elements here are really about something to do with meaning and purpose, something to do with a sense of connectedness, the search for the significant or the sacred, and that this is an aspect of humanity in general, spirituality, and that it includes a much wider umbrella, not just religious issues, but philosophical and existential issues as well. And, you know, to really operationalize spirituality and health, the World Health Organization, you know, in 83 and 88, took the steps to say, hey, listen, spiritual dimension of health is a core dimension of health. And so they added this word spiritual to their definition of health, that health is a dynamic state of complete physical, mental, spiritual, and social well-being, and not merely the absence of disease or infirmity. And there's a corollary definition for spiritual well-being, you know, realizing one's full potential in the moment to moment. And then a professor at University of Geneva really pointed out that the link between religion, spirituality, and health has been too often ignored for irrational, emotional, or political reasons. And she's really calling on the scientific community to integrate religious and spiritual factors which have guided human behavior over the centuries into the health and human sciences. So, you know, I think it's worth taking this more than just a call, but like taking it seriously. And I want to introduce this book to you called The Future Public Health by Hanlon et al., who's also in Scotland, it turns out, a medical doctor and public health researcher, and his colleagues wrote this book to talk about how can we really envision a new healthcare paradigm that can envision a different future. And that too often public health is limited by short-termism, like, you know, really short-term political, short-term goals in health, and reductionism. You know, just sort of reductionism is the way to think about things, and you don't really think about creativity and insight. And so in the foreword, this other professor of public health in the UK says that really we need to look at how the Western world, which is based on consumerism, individualism, competitiveness, and the workplace treadmill, doesn't lend itself to well-being, and that there are the things that make for well-being: uncommitted time, pleasure in others' company, creative endeavors, and giving to others. These get squeezed out. And so they talk about a new way of thinking about public health based on systems approaches that are holistic and integrative, and getting way past the Cartesian duality. And, you know, this professor of public health at Warwick, Sarah Stewart Brown, says we can't go on pretending that the mind and body operate independently, or that neither are affected by the state of our spirits. We have to find ways of thinking and planning that take into account their interrelatedness. And so that's where she calls for complexity theory and really bringing that into public health curriculum, and I think, you know, medical curriculum. So the way that they approach this is looking at the 4 waves of public health throughout history. The first wave being the great public works, sanitation, engineering. Wave 2, second wave in public health being the germ theory of diseases, scientific specialization and medical specialization in hospitals. Wave 3, welfare reforms, social security. Wave 4, the risk theory of disease. And this is another graph or table showing the different approximate dates of these. And, you know, this is centered around the UK, but this really applies to a lot of Western countries. And you can see on the bottom is like, it shows each wave, but each secondary successive wave is building on the previous wave. And so you carry forward what from wave 1 into wave 2 and so on and so forth. So there's been some tremendous successes in public health through these specific waves, focusing on these aspects of health and disease. However, in our times, late modernity, we are facing existential intersecting crises, complex and multifactorial, such as worsening obesity, rising loss of well-being, worsening inequality, rising environmental and sustainability crises, global climate change, human-led environmental degradation, peak oil, pandemics, rising rates of depression and anxiety, diseases of despair, suicidality, addictions, ongoing mass casualty violence and ongoing threats of nuclear war as well, population growth, and other major global economic crises and rising inequality. So the public health systems are just not equipped these waves to handle these complex crises, and they really pin a lot of these crises due to these aspects of contemporary culture, these isms: economism, materialism, consumerism, and individualism. And these are the definitions of these terms, and it's just really worth kind of picking them out and calling them out. These is the tendency to view the world through economic lenses only, society as an economy, rather than other types of values that would be important to people. Materialism and consumerism, I think we all know well, is the idea to acquire meaning, happiness, and fulfillment through acquisition and possession of material things. And these will outrank spiritual values and squeeze out non-material aspects of life. And individualism is important to also call out that this is an idea, an environment where success and responsibility of failure rest solely with individuals. And this can lead to a tyranny of excessive choices and higher expectations of life, together with reduced social support and social controls, which leads to an increased sense of risk, uncertainty, and insecurity. And so their call for, there's an emerging fifth wave of public health on the horizon, which is really focusing emphatically on well-being, centering around a new image of what it means to be human. And the features of this wave are integrative, ecological, ethical. Creativity is being sort of suffused all throughout the health system, and beauty. Qualities of this wave are recognition of complex adaptive systems rather than simple predictable systems, rebalancing our mindset from antibiotics and war on drugs, combating inequalities, to kind of a pro mindset, well-being, balance, integration, going from dominion and independence of specialist knowledge and expertise to greater interdependence and cooperation, learning from and with others, rebalancing our orientation, so bringing in objective measurements of biological and social processes and health with subjective lived experience intertransformation, and intersubjective shared symbols, meanings, values, beliefs, and aspirations. Next is developing a future consciousness to inform the present, thinking about different forms of growth beyond economic, and iterating and scaling up, learning from each other, rather than sort of a top-down rollout of new health systems. And this is important in medicine, because sometimes we have to experiment and try new things, and then share that information with others. And I think these are some lessons we can learn as we integrate entheogens into healthcare. Final point I want to make about this public health model is that they talk about how do we sort of reorient how we evaluate health systems and really health interventions. Is that really we want to go back to Plato's idea of mixing the good, or I should say the true, the good, and the beautiful. The true being what we know from science. The good being what do we know, what is the ethical or right thing to do in terms of balancing the scales. And the beautiful is how to bring art and aesthetics into healthcare system and health interventions. And part of what we've done in this clinic that I've started here is put artwork on the walls. And in many healthcare institutions, art is becoming, and we certainly do a lot of that in palliative care, but really taking that in a serious way, that's so critical to healthcare and health systems. And on the right-hand side is the Wilbur integrative model that's very, which the folks in the book rely on as well. And you can actually map this old Platonic view right into his 4-box model. And just to note that in our healthcare system, we've only focused mainly on the objective exterior dimensions of reality, the body, the physical world in medicine, and in society, at public health at large. This kind of objective view of society. But it's these other levels, the inner world, the subjective interior, and the collective interior that we need to really bring forth and reintegrate. And I think that's where a lot of the entheogenic medicine will help us move into those models more fully in our health system. So how do we build a healthcare system that is integrative, fifth wave public health, that it would be spiritually aware and trauma informed? So trauma is my next topic. And the reason I go into this in such detail is because existential distress and anxiety really is a form of trauma. And trauma is one of the most, this is from Peter Levine, one of the major social psychologists, or somatic psychologists of trauma. And we don't really talk about trauma much in medical school. It is one of the most avoided, ignored, belittled, misunderstood, untreated causes of human suffering. That's what Levine writes. And that it's not really an ailment or disease, but really a byproduct of an instinctively instigated, altered state of consciousness. And we enter this altered state, you can call it survival mode, when we perceive that our lives are being threatened. If we become overwhelmed by the threat and unable to successfully defend ourselves, we become stuck in survival mode. This highly aroused state is designed solely to enable short-term defensive actions, but if left untreated over time, it begins to form the symptoms of trauma, which can invade every aspect of our lives, and is a form of rupture, loss of connection. Really, again, that connection theme coming up. And this can happen slowly over time. And the contemporary view is that trauma is untreatable in psychiatry, and that you can just manage it with drugs to suppress the symptoms. But really, there's a transformative model that could lead to long-term healing. This is a image I got from Twitter showing all the different symptoms that are associated with trauma, everything from hopelessness, irritability, numbing, hypervigilance, all of these. And you can see some of these themes in existential distress as well. Another point that Levine makes is that we have the obvious causes of trauma. We think about war, childhood abuse, severe neglect, sexual abuse, rape, witnessing catastrophic illnesses, of course, we see in palliative care, but it can also come from less obvious potential minor, so quote, minor things, such as automobile accidents, invasive medical procedures, falls, being left alone, birth stress, prolonged immobilization. And I think this, I wanted to briefly introduce, I won't have time to go into much of this, but you should know that there is this amazing anatomist, Stephen Porges, who's developed a theory to understand really how does our physiological system adapt to safe, dangerous, and life-threatening environments. And it's not the simple dichotomy of fight or flight, rest and digest that we were all taught, that it's really actually 3 levels of neural circuits that help our autonomic nervous system adapt to different forms of life stress. And he calls this the polyvagal theory. And really what it comes down to is, if you look here in the this portion of the brainstem, that these are the different nuclei that the vagus nerve comes out of. And the ones that we are most familiar with are this dorsal motor nucleus. Actually, the ones we're most familiar with are this spinal trigeminal nucleus, which is sort of the mobilization sympathetic nervous system from the spinal cord. But really, the vagus nerve actually has these other roots. Number 1 is this ventral vagus. And this is what connects the face and the heart, the striated muscles of the head and the face to the heart. And this is what he's calling the social communication nervous system. It helps for self-soothing, calming, and it's part of the ventral vagus complex. And on the other side, there's the unmyelinated vagus, the dorsal vagal complex, which is the severe immobilization response, the reptilian response to threat, where you just play dead. And so I'll pass on this slide here, but this system has, we can divide functions of the autonomic nervous system into these 3 different areas. And really, we go through different layers of arousal, depending on, our neuroception. Is it safety? Are we safe? Then we can explore and attune and have curiosity and connection. And then, are we in danger? Do we need to, how can that will manifest in frustration, irritability, anger, rage, or defensive orientation? And then the severe state, freezing, and this is numbing, derealization, depersonalization, helplessness, defeat, which you can see in severe existential distress. And so the idea is, you can think about moving from this red to yellow light to green light, that this is really a system of inner physiology to understand how to heal from trauma and what spiritual health might be rooted in. And just briefly, I won't have time to go over this, but this is many people have said, well, where's the evidence for this kind of theory? There are more and more, this is a PhD dissertation from Berkeley grad student, now Professor Steller, which she showed that you can actually, using respiratory sinus arrhythmia, which is vagal tone of the heart, you can show that if you try to induce compassion in people in psychology experiments by showing them traumatic things, people going through suffering scenarios, that actually you can see an increase in respiratory sinus arrhythmia, which shows a link between prosocial emotions and the vagus nerve. And these slides will be available for use as a way, a sympathetic first aid, where you can use this system to help people get out of traumatic loops. In palliative care, this is one of my fellowship director, Ann Berger at NIH. She was really focused on why is it that there are patients that are seriously ill, terminally ill, that go beyond trauma, coping, and acceptance, who end up changed for the better or stronger mentally compared to where they were before. This phenomenon she's calling psychosocial spiritual healing. And she cites the work of Balfour Mount, who talked in his cases, a series of cases of patients that they looked at in palliative care using phenomenological study methods. How do they go to experience of suffering and anguish to an experience of wholeness and integrity? What are the features of that? And it's, again, connection, meaning, peace in the present moment, experience of a sympathetic, non-adversarial connection to the disease process, and ability to choose attitude to adversity, and open in the moment to greater, open into the potential in the moment greater than the need for control. I won't go into this, but NIH HEALS is a 35-item validated questionnaire. I actually participated in some of its validation during my fellowship training. It assesses positive transformation in response to challenging life events. It's a psychosocial spiritual measure of healing. And these are the factor analysis. So there's actually a tool that's been developed around this phenomenon. And they are using this tool in some of the psilocybin-assisted therapy trials in cancer patients. And we're using it here at our clinic for our outcome studies as well. Eric Castle, one of the famous clinical ethics professors, medical ethics, wrote famously in this article in the New England Journal of Medicine in '82 on the nature of suffering, that transcendence is probably the most powerful way in which patients are restored to wholeness after an injury to personhood. When experienced, transcendence locates a person in a far larger landscape. The suffering is not isolated by pain, but is brought closer to a transpersonal source of meaning and to the human community that shares those meanings. Such an experience need not involve religion in any formal sense. However, it is deeply spiritual in the transpersonal dimension. And so, we're moving into kind of, we talked about the problem, we talked about the framing of a theory, and now we're looking at what are the clues in palliative care that show us how healing is possible. What's amazing is there's lots of research from psychology, positive psychology, on awe. Now, people have done studies in laboratories, and I just wanted to show you some of those findings. Awe, title of my talk, Awesome Medicine. Awe is a self-transcendent emotion that exerts a powerful impact on the self. Through diminishing the ego, awe may help cultivate interconnection, wisdom, meaning, and purpose. Again, this is Jennifer Steller, who's now at the University of Toronto. Michelle Chiot at Arizona State says that in well-designed experiments, awe has been found to promote a heightened concern for others, feelings of connectedness, humility, helping of strangers, pro-environmental attitudes, and behavioral intentions. And really what she's saying is that the research is showing that awe helps us lower the filters of our mental models, seeing the world a bit more as it is, less influenced by our cognitive shortcuts and dominant assumptions. Now, awe also can be used by cult leaders, dictators, conspiracy theory pushers, and religious extremists to secure devoted believers who go on to commit atrocities against themselves and others. So, this awe is like a little earthquake in the mind, a moment of cognitive malleability, offering a chance to expand and reconstruct one's mental model of the world. And the model that emerges depends on what happens in the moments during and after encountering the awe stimulus. And we know far too little about that. This is why it's so critical in awe medicine to have a real sensitivity and in curation of the scenarios just before and just after, what we call preparation and integration. But this is true of all awe. And anyway, she goes on to say, Michelle Chiot, that people really need more awe in their lives. We have such a frenetic pace of modern life. She says, I need more awe in my life. And as we grow older, I know, Dr. Hirano, you're a geriatrician, people accumulate more and more knowledge and spend the bulk of their time in routine tasks and activities, and there's less awe. But awe is readily accessible. She says, and this is an important point, people might think, researchers and lay people think to experience awe is rare. You have to go to see the Grand Canyon, or go to the view of the Eiffel Tower for the first time. But she said this is no more true than the proposal that we feel fear only when being violently attacked by a tiger. Just as we experience a little bit of fear upon seeing a spider in the bathroom, we can experience a little bit of awe in the course of normal life. Anyway, let's now talk about entheogens. My last point about this is that we need to find ways to make meaning, that awe is part of that. And this is a way for us to get reconnected back to, being that social dimension of our nervous system, and that individuals need opportunities for consolation to create and renew their spirit. And it turns out that those italicized words I have on the slide is actually where the word recreation comes from. If you kind of fall into that trap of recreational or medical drug use, I think there's a lot more integrative view that we can look at once we start accepting and understanding the spiritual dimension of health. So entheogens, what is an entheogen? It's a chemical substance, typically of plant origin, that is ingested to produce a non-ordinary state of consciousness for religious or spiritual purposes, Oxford English Dictionary. It's not a pharmacological class of drugs. It's a class of drugs that provoke ecstasy and have traditionally been used in shamanic or religious inebriants, as well as their active principles and artificial congeners. And it can be chemicals, plants, fungi, animal secretions. It's more nuanced and neutral from the term psychedelic, hallucinogen, psychotomimetic. And there are many ancient healing traditions, shamanic healing cross-culturally, even in ancient Greece, the Eleusinian mysteries likely involved an entheogen, South America, many other entheogenic substances, but a DMT-containing brew called ayahuasca, psilocybin-containing mushrooms, mescaline cacti, ibogaine. This is a wider cross-cultural phenomenon. I put a couple of books up here, The Immortality Key, I highly recommend. I have a blurb in it here. I was just so amazed. He's really looking at what is the foundations of Western civilization, and could Dionysian rituals in ancient Greece have figured their way into early Christianity, Paleo-Christianity, and really been at the origin of the Eucharist. So entheogens are far more integrated into even Western society than we may have been taught to believe. This is the famous Chiopili statue that was found in Mexico, and down the Anthropological Museum, showing how much reverence Aztec culture had for entheogenic substances. This is somebody shown in a state of ecstasy and with several entheogenic biota carved on his body. This is a peyote ceremony from a painter in Oklahoma. I grew up in Oklahoma, and this museum was nearby my home. And this is the peyote bird emerging from a ceremony. Peyote contains mescaline. I had a larger montage here to show you really entheogenic practices all over contemporary society. On the upper left are pictures of the Santo Daime and Unio de Vegetal churches that have been granted permission to use DMT-containing entheogen in their religious practices. The upper left is in New Mexico. The next one is in Ashland, Oregon here. This is a ayahuasca brew tea in South America being poured. This is Maria Sabina, the Mazatec shaman, who is using mushrooms in a ceremony that was shown in Life magazine in the 50s. This is an entheogenic wine and wafer ceremony in a Catholic church. These are pictures in India of using cannabis ritually. A woman taking hits from a chillum. This is a bhang lassi, a cannabis drink on Holi, which is a big social carnival ceremony in India. This is from Pakistan, a man inhaling cannabis in front of a Sufi shrine, or a Sufi pier that's associated with cannabis. This is Ibogaine ceremony in West Africa, in Gabon, a powerful hallucinogen from a root. These are pictures of a Judaic shrine that has cannabis residue on its altar that was recently discovered. These down at the bottom, on the far right, is Evo Morales holding coca leaves at the UN, saying this is a sacred plant for his people. This is a Kaaba ceremony in Polynesia. This is snake handling in West Virginia, where people are drinking strychnine as part of their religious beliefs. These are all legitimate spiritual practices that involve some form of substance and transformation. These are the Salvia Divinorum ceremony, and this is the peyote ceremony. So this is entheogenic human behavior. Another way to look at these substances, and in the Harm Reduction Journal, I published this paper and showed the seeds of all of these plants that I've shown you in the previous slide. You saw all of them except opium and khat. But another way to think about how would you control seeds like this. So let's do some more definitions. That really what we more commonly use in medicine is this term psychedelic, which means mind manifesting. Mostly, often people thought about tryptamines. And there's the classic psychedelics, which are tryptamines like LSD, psilocybin, DMT, and the phenylethylamines, mescaline being one of them. And then you can think about novel psychedelics like MDMA, ketamine, Salvia Divinorum. And the mechanism of action of Salvia Divinorum was actually discovered at the University of Washington, the kappa-opioid agonist by Charlie Chafkin's lab. He was my psychopharm professor at medical school. This was one of the books that Aldous Huxley wrote in the 50s called The Doors of Perception. I won't go into this due to time constraints, but he describes the idea of experiencing mescaline, which is what he writes about in this book, as a gratuitous grace. And he says, to be shaken out of the ruts of ordinary perception, to be shown a few timeless hours, the outer and the inner world, not as they appear to an animal obsessed with survival or to a human being obsessed with words or notions, but as they're apprehended more directly, is an experience of inestimable value to the intellectual, to the philosopher, and to the palliative care patient, to the chronically ill patient. Craig Blinderman, who directs palliative care at Columbia, writes a return to entheogens in this paper in 2016 when they published one of the first studies showing mystical experiences with psilocybin in patients with cancer. And he says that this is really, this is a place we need to explore. So now let's zoom in. This is psilocybin. This is how it's synthesized in the mushroom. It turns out it's very similar to tryptophan, which is an amino acid. It's very close to it. Just a few steps. This is how mescaline is synthesized in the cactus. It's very close to dopamine. You can see this, the dopamine molecule here and the steps it takes to get to mescaline, not very far. And this is how dopamine is synthesized on the left there, and epinephrine. So we can talk a little bit about the direct mechanisms of action now, going into biomedical effect, psychotherapeutic catalysis, and experiential levels. What's amazing is that there's been so much research in the last few years on the neurotheology or neurospirituality. And people have looked at the role of entheogens at the level of gene expression, how it affects neural networks, how it looks at a disintegration of what's called the entropic brain theory. So I won't go into all these details here, but you'll have it for your reference. There are so many different mechanisms of action, downstream effects of signaling cascades after the binding of the 5-HT2A receptor, which is I'm using the tryptamine example. And these different gene expression models have been looked at for synaptic plasticity in the rat brain and other early genes being turned on related to plasticity. And then at the cellular level, these different neural populations in the prefrontal cortex and the colostrum, which become activated, and also internalization of the receptor, of 5-HT2A receptor, which seems to be associated with a reduction in anxiety and depression. Also effects on the glutamate system, enhanced glutamatergic transmission, and decreased BDNF, which you normally see in depression, brain-derived neurotrophic factor. It normalizes with antidepressant therapy, and you can see it in the effects of ketamine, which is has rapidly acting antidepressant properties. So these are some of the mechanisms, and this is the regional brain level. So much work done by Robin Carhart-Harris at King's College London, Imperial College London, excuse me, showing these the diminished activity of the default mode network, allowing connections between other areas of the brain that don't normally talk to each other. And this is where he kind of develops this thing called the entropic brain hypothesis, showing that really we have low energy, low entropy states, could be deep sleep, coma, sedation, OCD, rigid thinking, and then normal waking consciousness, and then higher entropy states, such as the psychedelic state. But also REM or infant consciousness. So that's this is what's emerging, the understanding of how we get to these different states of awe and loose cognitive binding. It's a kind of an entropy theory. And this is the connectome's famous image of what kinds of brain states, resting states on the left in controls, and then under the influence of psilocybin, how so many areas of the brain are now in functional connection with each other for this period of time during the effect of the medicine. So I coined this term entheogenic integrative care, because we can use this knowledge and understanding to really put into practice what we know now. And this is what entheogenic integrative care is. It's knowledgeable about entheogen use practices, promotes their respectful, protected, safe, and beneficial use, makes integrative evidence-informed prescriptions and or recommendations related to the use of entheogens that can be to reduce risk, harm reduction, or for therapeutic purposes, such as drug-assisted therapy, in which we utilize preparation, non-directed or inner-directed experiential guidance and integration phases. It's used to treat disease, prevent disease, and promote well-being. Looks like 8:48. I don't have as much time as I have for the rest of these slides, so I'm going to skip some of this stuff, but this is just what we've learned in my clinic on how we use ketamine in an entheogenic fashion, and we take these steps. We take preparation phases, and I've treated a number of patients with advanced illness and cancer, and patients with my colleagues in the psych, on our psych side of the fence, take care of patients with PTSD, OCD, depression, anxiety. It's a preparation is about establishing that rapport and that connection, getting ready for these mystical state experience. This is what the experiential dimension, this is the different characteristics of mystical state that have been described previously. And I won't go into all of this. You've kind of seen shades of this throughout the talk. But just something I think it's worth noting is this idea that this is ineffable. You can't really, it's a state of feeling rather than a state of intellect. So it defies description in some fashion. And so when somebody's in a state like that, or just coming out of that or coming into that, the healing modality that's been best accepted by many of the groups that are developing psychedelic medicines into approved drugs is an inner directed approach. Really not using that as a time to tell people things or advance any kind of agenda, but really to help a patient go back to their inner guide, their inner healing wisdom, and allowing the process to unfold so that they can get back into the more relaxed social nervous system, so that they can process whatever's coming up, and so that you're not sort of unduly influencing the patient. But creating the proper setting and intention, and then aftercare, so that you can facilitate healing. These are some of the integration practices that people use: listening to music, listening to audio or video recordings, singing, drawing, dancing, yoga. There's more details here, but I'll let you look at that for later. So now I want to talk a little bit about specific substances. Cannabis is one of my interests. That's what I did a lot of my doctoral research on. Cannabis is an entheogen as well. And so I wanted to just highlight that in the second area, that people can use cannabis for palliation of existential and spiritual suffering due to its abilities to provide euphoria, extinguish aversive memories, and heighten the senses. And I just wanted to show you a little bit more details about what exactly that looks like. We won't go into that in much detail here. And really tell you, there's somebody has some great, I hope somebody captures these citations that are going in the chat. There's some great, I know James Kahn, he's working in the DC area when I was there doing my fellowship. He's an excellent rabbi. Yes, so cannabis signaling cannabinoid signaling ties into all of these functions in physiology. And this is part of why cannabis exerts the effects that it does. And I'll skip this, but you should know that there's lots of research on cannabis and the endocannabinoid system. But what I wanted you to pay attention to is that people don't look at this enough. There are studies, this is from the American Journal of Public Health, that the suicide rates go down in states after they legalize medical marijuana. This is a collection of all male suicide rates from the National Vital Statistics X number of years after they changed the law versus control states who didn't change their law. The mean suicide rate drops in males. In females, it doesn't drop as much, but there's still an effect. And this is another study showing gun violence. Specifically gun suicides in California dropped after medical marijuana was legalized. There was 208 less gun suicides per year. So that to me is another indicator of its role in existential healing. Ketamine is the first antidepressant with a novel mechanism, says one of the directors of the NIMH, and it's a huge breakthrough in its ability to rapidly decrease suicidality. Many people are calling for the use of ketamine in palliative care in this entheogenic fashion. Our colleagues in Canada have been done more work in this, and ketamine has its sort of quality of its entheogenic visionary experience is very close to a near-death experience. Many people have described that, and that it's sort of unique in that way compared to other entheogens. This is some work from Krupitsky and Kolb, who are Russian, in the Soviet era, did work on ketamine in Russia and then in the United States, and they saw all these different features in their patients who were undergoing ketamine therapy. This is from NIH-funded studies showing the actual sprouting of dendrites after one day, in a rat model, a mouse model, a mouse is given ketamine after being chronically stressed for 21 days. You get more dendritic sprouting integrated into the neural network. So this is just really showing that plasticity in neurogenesis. I will pass on this for now. I trained from Wolfson and Julian Andrews on ketamine-assisted psychotherapy. They have trainings, and they really use ketamine in this much more drug-assisted way. They learned from the MDMA therapy program. And I can go into that later, or you can study this in the slides later, showing the improvements in depression and anxiety is a nice study that was published recently in a pooled analysis of 235 patients using ketamine. These are some of the side effects: nausea, vomiting, agitation. In palliative care, this is from Joshua Biddle, presented at this year's AAHPM meeting. So we have early studies from the 60s and 80s on cancer patients, and the modern trials, UCLA, Hopkins, NYU. I got to participate with the NYU study group when I was a resident there, which was an amazing experience. And then there are studies at UCSF on long-term AIDS survivors. And of course, the MDMA therapy, recently published study in life-threatening illness as well. This was sort of the big book that How to Change Your Mind by Pollan that really catalyzed a big awareness in the community. As Dr. Toronto was saying, patients are reading this and hearing about this and will have questions. These are some of the psilocybin studies, the controlled clinical trials. And there's 3 that have been done in the United States in cancer patients, which I'll show you a pooled analysis of those in a second. And this is sort of, I wanted you to see it. I thought if we had time, I was going to go into the design of one of the clinical psilocybin trials on depression, major depressive disorder, where they treated 27 patients, but it's 8:55 now, so I won't have time to go into that. But I wanted you to see the significant changes. This is, well, what do you think, Dr. Hirana? Should I stop now, or?
I think I'm going to guess that some people have questions. So I do want to open it up to questions because I think the evidence is on your slides and we can all definitely sift through that. But I think hearing from you and having you here as our content expert is really helpful for folks who want to ask questions directly of you. So if it's okay with you, Dr. Aggarwal, I'd love to open it up to questions. And please just unmute yourselves and don't be shy, jump in because time is limited. So
I'm going to just, I'm going to sift through these slides so you can kind of see what I was talking about as we hear these questions, so you can have it in the background. Go ahead. Somebody have a question?
I have a question that is, in your clinic, how much access to, what are the demographics and communities that have access to this information and to this approach to medicine? Because marginalized communities have a lot more experience, a lot more trauma, and yet seem to be not able to access it as much. So that was one of the questions I had.
Yeah, I think I've seen it. It depends on. I still don't have a clear social understanding of that. I think absolutely there's a lot of work being done on use of entheogens to increase accessibility to marginalized communities. The MAPS people are trying to do that. They've created special workshops where they want to train therapists of color. But when they tried to do a study in Connecticut, they had a very difficult time enrolling anybody, which was specifically focused on marginalized populations. And I know that some of the therapists in that trial have written some reflections on that. I haven't had a chance to read their.
I guess I was kind of interested in your clinic, but I want to allow time for other questions. Yeah.
Here, I would say, we don't take Medicaid, and so we're on a few panels, but without having grants to operate, it's very difficult to sustain yourselves in private practice with Medicaid, and so that really limits our accessibility pool. And then on top of that, ketamine-assisted psychotherapy is considered experimental by major insurance companies, so we can't bill it. So these are some of the access barriers. We try to find ways using home approaches or groups to reduce the cost for patients, and we are getting some patients. Usually, it's middle income groups that are most common demographic that are accessing this type of therapy. I'm working on a project of Right to Try, which I have a slide here, to get psilocybin for some of my terminally ill patients who hopefully will help to reduce some of these barriers if we can get approval.
Thank you.
These are some other slides. Microdosing in pain, a recent study. A lot of people are interested in microdosing.
And nobody else has any questions, I'll go in. You've got a number of spiritual care providers on this grand rounds. What is your relationship? How have you incorporated spiritual care providers into this approach, or have you?
I don't have a chaplain in my clinic, but I think there's if you look at Harvard Medical School, they recently, or the Divinity School recently did a psychedelic chaplaincy training. And I think this is like an emerging field in chaplaincy. More and more chaplains, I think, are extremely, in the palliative care team, one of the best equipped with integration and preparation and potentially even guiding. And I think it's a matter that's, it's for the taking. I think there's another professor I know at Naropa Institute. I'm blanking on her name right now, but she's also, I think she presented at the psychedelic chaplaincy event at Harvard, and I encourage folks to take a look at that. I think that this is an opening. We're at the beginning of this, and I think spiritual care practitioners are, well equipped. And as far as what we do in my practice, really, it is just being attentive to that spiritual health history and being aware of the integrative model of healing, where spiritual distress and spiritual well-being are part of our, we allow space for that. Mm-hmm. I think that's really just acknowledging that, I think goes some distance. And my hope is to do ketamine therapy for hospice patients. I have a home palliative program that I've thought through. I haven't found any hospice patients yet who've wanted to take me up on that. I need to work with the hospice medical directors. But my hope would be to use the rest of the hospice care team as part of that process for the preparation and the integration work. So that would include the chaplain. Thank you so much, Elizabeth, for your questions. I know we're out of time. I'd be happy to, I have some time to stay on if there's more questions, or you guys can let me know what you'd like to do. My email address is at the end here, Aggarwal at Ames Institute, where is it at, right here, or info at Ames Institute will also reach me. And I'll make these slides available. I sent them to Shinitra, so please pass that on. And I've got lots of citations here for further reading. These were my take-home points in case you want to see that spiritual health is a vital dimension of health, and that healthcare based in the fifth wave of public health must be willing to address trauma and existential and spiritual distress at the level of the interior, and we must be willing to try new approaches. I think we can practice entheogenic integrative care even now with several entheogenic substances, even if it's from a harm reduction standpoint. We have lots of clinical evidence on the therapeutic value of entheogens, and that an integrative team approach is an important way to approach. And in my clinic, I work with psychologists, psychotherapists, naturopathic physicians, psychiatric nurse practitioners, MD physician myself, and I think many such integrative models can be developed in palliative care settings, and I'd love to see that happen. And I do want to pay some respect to Tony Bach, who's in our department and has done a lot of work on really breaking the sound barrier on psychedelics and entheogens, describing his own experiences with psilocybin as a way to actually improve his ability to communicate with families. And so I think there's a lot to be said for training, with experiential training with psychedelics or entheogens. And we are doing ketamine-assisted therapy for practitioners at our clinic, and I hope to see more of those kinds of things in training in the future. So thank you to Tony Bach, if you're out there. Anything else before?
I think we can take one more quick question, and then I think we'll close ourselves out. I know I have to jump off at 9:05 for the fellows didactic, but any last, I know Justin, you're unmuted. Was there any last comments or questions? We have time for one more.
No, I think, at least from my perspective, coming from an indigenous family in Mexico, that just a caution that in this really, really important research, which I love the way that you presented it and really on board with what you're doing, is just caution not to separate these from their indigenous and cultural links and heritages in multiple cultures and places around the world. We've seen that in mindfulness and how that has been stripped of a lot of its spiritual heritages, and which has caused some damage to people. And so just a caution that we don't go down the same path with these.
Thank you.
And with that, I think we'll close out Grand Rounds. Thank you so much, Dr. Aggarwal. This was fantastic. I think, it just really speaks to palliative medicine and how we really want to treat the whole person. And there's so much to the whole person, right? There's so much to each individual. And we all know that existential distress is one of the hardest things to treat. And so if these new tools can, or old tools, ancient tools, can start helping us down that path a little further, I think that's always a good thing. So thank you again for presenting this, and thank you for all of the resources and knowledge and wisdom on this topic. And we hope to make the slides and presentation available because I know there was a lot of content in these slides that people will want to review at their leisure. So thank you all for joining us. There's no grand rounds next week. We're taking a break for spring break, and then we'll resume the following week. So please rejoin us. Thank you.
Bye.